Go ahead.
I got your recording.
Okay. Hi, everyone. My name is Steve Long. I'm one of the anesthesiologists at Oakland. And the topic over the next 15 minutes or less is TEG, which is thromboelastogram. So, TEG is essentially a measure of blood clotting efficiency. That's the way I think about it, at least. We draw a lot of labs that give us an idea of clotting function, but there isn't any test that brings all of the factors together in one. The TEG looks at coagulation factors, platelet function, clot strength, fibrinolysis, looks at all of those. And there's no other lab test that we have that does that. The way that it works is you draw a sample of blood, whole blood, you send it to the lab. That blood is placed in a little cup, and the cup is rotated like 6 times a minute. So it's trying to represent sluggish venous flow. That's the idea. And then a little tiny wire is put in that cup while it's being rotated, and a clot forms around that wire. And that process is then graphed. And so we get an idea of how long the clot takes to form, how big the clot gets, and then how long it takes for the clot to break up. And that's exactly what happens when, blood clots in real time. So it's a functional, the TEG it's a functional test. It's really looking at how well blood clots and how good those clots are. So I've got here a slide, and this is really my only slide, but it's got everything you need to know in it. And I'm going to start actually with, B down here. This is the graph of the TEG. TEG again, thromboelastogram. So this is a normal graph, and it has a whole bunch of different parts to it. So there's something called the R, the K, the angle, the MA, and the LY30. I'm going to go over each of those right now, but these are the factors that are reported to you. So the R stands for reaction time, and it's the number of minutes from when the test is started to when there is any evidence of a clot. So from when it started to when the clot just starts to form. And so, the longer an R is, having a really long R is abnormal because it means that it takes a long time for the clot to form. And that usually means that your coagulation factors aren't working well. It doesn't have anything to do with platelets. It just has to do with the coagulation factors, the coagulation cascade. The K is your next number. So the K measures the number of minutes from when the clot starts to form to when the clot is 20 millimeters in diameter. So it actually is just looking to see how long it takes from when the clot starts to form till it reaches that size of 20 millimeters. And so that's the second measurement. It's also in minutes. And it's also measuring, coagulation factor function. Then what happens is, so this distance, if you can see my arrow here, this distance here from the top of this line to the bottom of this line is 20 millimeters. That's what it is. It's 20 millimeters. It always is 20 millimeters. And then the clot keeps getting bigger, right? It gets bigger than 20 millimeters. And the angle, if you look at the tangent to this graph at K, that's called the angle. And it's kind of looking at how quickly the clot is getting big, that's measuring the angle. So then the clot will keep getting bigger until it reaches a point called MA, which is maximum amplitude. So that's the biggest the clot is, MA, maximum amplitude. And then, like all clots, it'll start to break down. And in what basically the last thing that's measured as part of this report, the TEG report, is something called the LY30. And LY30 is the percent of the clot that has broken down or lysed after 30 minutes from MA. So once the maximum amplitude is achieved, 30 minutes passes, and we see how big the clot is at that point, and see what percent of it has gone away or lysed, and that's your LY30. So if you look down here, it shows you what the normal values for these different factors are. So if normal R is 5 to 10 minutes, normal K is 1 to 3 minutes. And if those are prolonged, the recommendation is to give coagulation factors. So that's FFP. You would give FFP if R or K are abnormal. Then the angle, to be honest with you, I look at the angle sometimes. It's not the most important thing here. But if the angle is really low, if it's taking a long time for the clot to grow, then the recommendation, and the angle is abnormal, then the idea is that we don't have enough fibrinogen, and the recommendation would be to give cryo. I almost certainly, if your angle is abnormal, your K is also going to be abnormal. And so you will have already probably given FFP. So you give FFP and cryo. So MA is the next variable here, and MA, maximum amplitude. If MA is not, and it's being measured in millimeters, 50 to 70 millimeters is a normal size of a clot. Remember, it's going from 20 millimeters at K to the MA. If you don't reach that range, then the idea is that you need more platelets, because platelets are bringing the blood, it's bringing it together, it's forming the clot, it's making it bigger. Without platelets, you can't get a big clot at all. So if MA is too low, then the recommendation is to give platelets. And then finally, if the clot falls apart, if it lyses really quickly and your LY30 is high, if 30% or 40 or 50% of the clot is gone after 30 minutes, then you should give TXA. You're in a state of hyperfibrinolysis. So I hope that makes sense. So, R is the reaction time. I'll just go over this really quickly. R is the reaction time. It's the number of minutes from when the test is started to when there's any evidence of a clot forming. K is the number of minutes from that point to when the clot is 20 millimeters in diameter. If either of those are abnormally long, then you would give FFP because the coagulation factors aren't working. Your angle is the tangent at K. It's really how steep and how quickly the clot is forming. And if that angle is not steep, if it's taking a long time, fibrinogen is the problem. You can give cryo. MA is the maximum amplitude. It should be between 50 and 70 millimeters. The clot should be that big. If it's too small, then give platelets. You have a problem with platelets. And then LY30 is the percent of the clot that's lysed after 30 minutes. Typically, we would see 0 to 8%. That's normal. If it's more than that, then you have a problem. You have too much fibrinolysis, and you give TXA. So this talk's almost over. I just wanted to show you a couple schematics of different tracings given different clinical scenarios. So if you look at A here, we're going to go over all this right now. So if you look at A, this top tracing, TEG tracing, is normal. Now, all the other tracings, the dots are the normal tracing, and the solid line is the clinical scenario. So if you go down to this tracing, I hope you can see my arrow, the one right below normal. This is when the patient's on an anticoagulant like heparin or warfarin. And what you see here is what is abnormal. The R is abnormal because it takes a long time for the blood to clot. It takes a long time for the blood to clot. You just don't form a clot, right? It takes a long time. And then eventually you will reach your maximum amplitude, but it just takes forever. It takes forever. And that makes sense because, patients who are on heparin, I mean, they will eventually form a clot. If you hold pressure long enough, the clot will form, but it just takes forever, right? Okay. This second one here, look at this. So the clot forms in a normal amount of time, but it never gets that big. It never gets that big. And then it kind of, peters out quickly. Well, that's a problem with platelets. The clot starts forming with a normal amount of time, but then it never gets big. So that's a platelet dysfunction. This final graph on the left, the clot starts forming in the right amount of time. It basically reaches a maximum amplitude, but then it just dissolves. It just completely dissolves. And that would be a case of hyperfibrinolysis. So a couple more of these graphs here. I'm going to go over 3 more and then this talk is done. Here, of course, we're talking about patients who bleed too much, but there's a possibility that they're hypercoagulable, right? And in that case, your maximum amplitude would be bigger than 70 millimeters. So patients that are clotting all over the place, the TEG also will pick that up. And the graph will look like this. It will look more fatter than a normal graph would. And then as you know, DIC is one of the worst conditions for coagulation. And you can have you can have thrombosis with hyperfibrinolysis. And so if you have thrombosis, the clots get really big in DIC, and then the LY30, they break down faster than you would expect. So they get really big and they break down. And you can see that on this graph, right? The TEG actually shows you that this is happening in your patient because the clot forms and it gets really, really big. And then you see how it starts to break down faster than normal, than you'd expect. It's kind of going down. So this is a case of DIC with thrombosis and secondary hyperfibrinolysis. And then the final thing, DIC can be the opposite, where your platelets just aren't working at all. And you're oozing all the time. You just can't form a clot, and the clots that you do form are not that robust. So that's a terrible situation to be in. And in that case, you'd have a really long R, and then your angle would be really flat. Your K would you may not even reach 20 millimeters. I mean, and your MA would be pathetic. So, I mean, this graph right here is really bad, right? You have a problem with coagulation factors. You have a problem with platelet function as well. So in summary, the TEG thromboelastogram is a test that we use for blood clotting efficiency, like how well does your blood clot? It's a functional test. It gives you an idea about coagulation factors, about platelets, about fibrinogen, and about fibrinolysis. And it's a visual test, which is why I like it so much. You really can see what's going on. And in our lab, you can call, I mean, it obviously takes a little while for this graph to be produced because, you have to wait till the clot forms, and you have to wait until the clot gets big. And then you have to wait 30 more minutes after that for the clot to lyse. But if you can imagine, your R is going to be reported before your LY30. So you can always call the lab and see where they are in making this graph. If you're in a pinch and there's an emergency, and you may be able to get some of these variables early. You may not have to wait necessarily until the whole graph is done before you get the information you need. So thank you very much for having me.
Just one question, Steve.
Yes.
Is it contraindicated to give TXA at the beginning of a trauma, or should we be waiting until the TEG comes back?
I would draw the blood before the TXA is given. But you can give TXA without having this result back. So TXA will affect the TEG graph if the patient is experiencing hyperfibrinolysis. The TXA will treat that, and you may not pick it up if the TXA is given before the TEG sample is drawn. However, I do not think that giving TXA is that dangerous at all. And a lot of patients who come in for traumas are acidotic and they are cold. And both of those things can cause clots to break down. So I think TXA is pretty benign, and I would give it in patients who have evidence of bleeding.
Perfect. Thanks so much, Dr. Long.
Sure.
In a pinch, you did great.
Okay, good. I know.